ನಮಸ್ಕಾರ ದುರ್ಗಾದಾಸ್ ಸರ್.
ನಮಸ್ಕಾರ ನಮಸ್ಕಾರ. ಆಫ್ಟರ್ ಲಾಂಗ್ ಟೈಮ್, ಬಹಳ ದಿವಸ ಆಯ್ತು ನೋಡಿ. ತುಂಬಾ ಚೆನ್ನಾಗಿ ಬಂತಂತೆ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪ್ ವರ್ಕ್ಶಾಪ್. ಬಂದವರೆಲ್ಲ ಪ್ರೈಸ್ ಯು ಲಾಟ್. ತಮಿಳ್ನಾಡಿನವರು ಅಪ್ರಿಶಿಯೇಟ್ ಮಾಡಿದ್ರು. ನಮ್ಮ ಅಣ್ಣನ ಫ್ರೆಂಡ್ ಬಂದಿದ್ರು ಇದರಿಂದ, ಎಲ್ಲಿ ತಿರುನಲ್ವೇಲಿಂದ. ಕಾಲ್ ಮಿ ಅಂಡ್ ಟೋಲ್ಡ್, ನೋಡ್ರಿ ಎಕ್ಸಲೆಂಟ್ ಜಾಬ್ ಅಂತ ಹೇಳಿದ್ರು.
Good evening, Vidya ma'am. Really, it was nice.
Hi, Ashka.
Yes, ma'am. Good evening, sir. MJ Ramat sir.
Good evening. Good evening. Good evening.
Good evening, Durgadas sir.
Good evening. Good evening, everybody.
Yes,
Good
sir.
evening.
Hafiz Rahman sir. Good evening.
Good evening.
How are you, sir?
Fine, good.
I remember you every day, sir.
Everybody remembers him, yeah. Every day.
Yes.
Please, good evening. Hafiz, good evening. I am Dr. Durgadas.
Good evening. Good evening.
I had come to you so many years back
Okay.
for lab training. Good, maybe.
Yeah.
So many years back, the initial days.
Sir has trained everyone.
Yeah.
He's a torchbearer for so many procedures.
Yes.
So we just copy his procedures.
Yes.
Good evening, everyone. Sir, shall we start, sir?
Yeah.
You can start.
Just can you tell me whether this video is coming on screen? Just hold on a moment.
Yeah. Just show us.
Just I will
Yeah.
I will
Arun,
share
2
the
minutes.
screen.
Wait for 2 minutes, Arun.
You have to let me share the screen.
Yes, sir. Yes, sir. Please, sir.
Okay.
Yes,
Is
we
this
can
video
see,
coming
sir.
now?
We can see, sir.
Hello.
We can see the video.
You can see the video?
Sujal,
Yes.
actually, one code.
Little blur.
Yeah, but that's
Needs
okay.
a little-
You can see the video now.
Yeah.
Yes, sir.
Yeah.
Yes, sir. Yes.
Fine. So we can start now.
Yes. Arun.
Sir, please stop sharing, sir.
1 minute. Okay, fine.
Yes.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Good evening and namaste to everybody. A warm welcome to our esteemed speaker, Dr. Hafiz Rahman sir. At the outset, I would like to introduce our program, mainly for the benefit of our today's guest speaker. Sir, KCOG is a association of more than 30 years and doing extremely well in academics for the last 30 years. And we started this program of Karnataka College of Obstetricians and Gynecologists last year in the February. And every week we are having this program on different names, starting with first Thursday CPAP, then skill transfer, then international program and national. Almost every week we have the program. Quite a long time we were looking for you, sir. Somehow now Dr. Vidya has brought you today. Really everybody will be very happy to listen to you, sir. And this program has got the points also for those who want to have a fellowship and who wants to have a KCOG fellow. So these programs have become extremely popular, sir. And today, Dr. Hafiz Rahman sir will be speaking on a very simple topic, pelvic floor. We all know in the olden days, 30 years back, when we joined as a postgraduate students, only surgery we used to see is pelvic floor repair. And if there were 10 gynecological cases, 6 used to be the treatment for prolapse, surgery for prolapse. And nowadays, you know that with lot of advancement, the pelvic floor problems have come down. May not be so much as it was earlier. However, now also we have got a pelvic floor problems, and understanding of the pelvic floor problems has gone a long way. What we used to learn earlier and what is to be learned, especially after the invention of the laparoscopy. After the advent of laparoscopic surgeries, the pelvic floor understanding has improved. And today, Dr. Hafiz Rahman sir will be speaking to on management of pelvic floor disorders laparoscopically. I think this is a very wonderful topic. I think everybody is looking for this topic, sir. I think as all of you know that sir is such an experienced person. He has conducted so many workshops in India, abroad. I think Vidya, sir will definitely make this day very, very fruitful to all our seniors and juniors and even the residents also. With this brief introduction, I invite Dr. Vidya, our secretary of KCOG, to introduce the today's guest speaker, Dr. Hafiz Rahman. Vidya.
So thank you, sir. Thanks for the opportunity and giving me a free hand to choose the speakers.
Yeah.
And every time I ask you and you just say, Vidya, you choose. So that's so nice of you. Thanks a lot. And good evening to everybody and respected KCOG and KCOG office bearers. It is my great pleasure to introduce Dr. Hafiz Rahman. They say that as you go up in the career or as you go up in the ladder, your CV becomes smaller because the achievement is so much that just like the sun, you know, the sun shines always. So the same way, Dr. Hafiz Rahman shines always in his surgical procedures. So to introduce him, he's a torchbearer of endoscopic surgeries, many surgeries, and he has patented so many surgeries like the hysterectomy. It is the sunrise technique. I think most of them in India and abroad follow this technique. He has also channelized so many procedures like in endometriosis, pelvic floor procedures. So to introduce his capacity of a chair, he's a chairperson of Sunrise Group of Hospitals. There are many hospitals in India and abroad, and he has been the MCI chairperson also. And of course, he has been consultant to many, he has held position and consultant to many hospitals in India, Dubai, and Africa, which I have been to those centers also. And also, he has done so many procedures. Like it is each procedure, he has patented so many things like, okay, if you do like this, there'll be complications. If you do like this, this is the right path. So he has shown the youngsters the right path of doing many surgeries, and one of them is pelvic floor surgeries. So today we are going to learn from him the supports. We talk about so many supports and the POP-Q, the D-Lances, but when it comes to correction, the dilemma is, do we use the mesh? We don't use the mesh, or where do we use the mesh? And do we approach it vaginally or go laparoscopically? So may I ask Dr. Hafiz Rahman sir to enlighten us on this surgery and management of pelvic floor repair. Over to you, sir.
Thank you, Vidya. I'll go ahead to share my screen. Can you hear me? Can you hear me?
Yes, sir.
Yes, sir.
Yeah.
Yes, sir. Yes.
Okay. So basically, see, pelvic floor, as you have rightly said, is a bit complex thing and which has evolved a lot during the recent years of practice. And today, actually, we are not doing anything which we learned during our postgraduate days. And possibly the only surgery which we may do combined with the newer methods is like what I did yesterday. It's Fothergill's operation. So that is the only procedure which we do, which we had learned during our postgraduate days. All other procedures have actually become almost obsolete. So vaginally, see, we were doing a lot of vaginal procedures in Vidya. How much time do I have? Hello?
Sir, you have 40 minutes.
Okay. So we were doing a lot of vaginal procedures, and we found that the whatever vaginal procedure we do, whether it's cystocele repair, rectocele repair, sacrospinous fixation, unilateral sacrospinous, bilateral sacrospinous, with mesh we were doing. We actually had our own method of putting the mesh in the vagina with a wing-shaped mesh with both sacrospinous fixation. All those things we found that there is a lot of recurrence which was happening. So basically the recurrence, we all know that the pelvic floor prolapse is not just because of the birth trauma. The basic problem of the pelvic floor prolapse is the congenital defect of the collagen. You know, even though we talk about a lot of supports of pelvic floor, like level 1, level 2, level 3 supports and all those things, but the basic support is the collagen. That's a fascia which holds the bladder, the rectum, and the vagina upwards. And these ligaments, which we call as a support, are basically condensation of the fascia at different points. But you should understand that we know only just 10% of these ligaments. 90% of the ligaments are staying unknown. And we have slowly started, when we dissect into the pelvis, we have slowly started understanding these ligaments, and they are at multiple levels. So what happens in the pelvic floor relaxation is that these ligaments, which are there, hundreds of them, gives away. And that is a basic reason for the pelvic floor relaxation or prolapse. We may think that it is due to multiple birth traumas, but that's only a very small factor. The multiple birth traumas usually makes trauma basically to the levatrinae and not really much onto this collagen framework. Because we have seen in many of the patients, like the Arab patients or the African patients, they may come to you with 18 normal deliveries, and they really don't have much of pelvic floor problems or uterine prolapse, even after so many deliveries. But in our Indian population, we find that the pelvic floor relaxation or pelvic floor prolapse is much higher, same as in the Caucasian and the Chinese population, which we see. So this collagen is different. Collagen is the main thing which creates this problem of pelvic floor relaxation. Now, to understand this concept, we need to have certain concepts, because initially we tried repairing this collagen, and later on we understood that repairing this torn collagen or the defective collagen is absolutely of no use. That is the reason why we started getting a lot of recurrences. We used to trim the mucosa and think that for the time being, okay, this histocele is gone. But it recurs back again within no time, basically because we are not correcting the defect. Then we all understood that mesh has to be the thing which safeguards this recurrence. And we started putting mesh initially vaginally. You know what happened to vaginal mesh. I don't have to tell you, because those are become old stories. The vaginal mesh had a lot of problems because of obvious reason. I'll get into that. And more than that, infection. Infection was a big problem in cases of vaginal mesh. Now, the concept of mesh itself has changed completely. And let me get back to you on the concept of mesh. Initially, what we were telling is that this mesh will allow, you should have a macroporous mesh where you allow the fibroblast to grow into it. The fibrous outlay becomes a part of the mesh. And then you have the contraction of the whole thing, and this will hold the pelvic floor upwards. So this concept is completely changing in our practice today. And we should put the mesh in such a way, in our concept, says that we should put the mesh in such a way that there should not be any fibrosis. One, there should not be any fibrosis. Two, the viscera should not get adherent to the mesh. Viscera should completely move on the mesh. Because we have seen that since long years we are doing this mesh surgeries laparoscopically, we have seen that those cases where there is mesh fibrosis, those are the patients who have come back to me after 6 years, 7 years, 8 years with long-standing pelvic pain. So that's how we thought that how to reduce this thing also. So that is where we understood that we have to have a correct concept of the pelvic planes, which is extremely important. If you see this diagram on the right side, you can see that, in between every viscera, this is the cervix, okay, and the uterus, you can say, and between the rectum and the uterus there is a nice plane here. These are the ligaments, but you should understand this plane is there, and between the bladder and the cervix there is another plane. So these planes, or these spaces, you can say that as pelvic spaces, are the spaces which God has created actually. Which God has actually created in such a way that you can do the surgery, you can go into the spaces very nicely. And the advantage of this space, this is known as the holy space of heel. The advantage of this space is that this space does not have the nerves, this space does not have the vessels, and this space is a space where you will not get much of fibrosis on the mesh. You will not find much of fibroblast growing into the mesh. You know, what are the problems is fibroblast or the fibrosis growing into the mesh, or the mesh getting adherent to the viscera causes? One is chronic pain. Okay, the viscera gets pulled up, that's fine. But then when the mesh gets adherent to the viscera, there is all chance that mesh can also erode into the viscera. Because, see, if you go out of this space, suppose you go out of this space and get into this space and keep the mesh here, very close to the musculature of the rectum, the muscle slowly contracts and it actually pulls the mesh inside to the rectum. Always the pull is towards the hollow viscera. So it pulls the mesh inside to the rectum. And that is the basic reason of mesh erosion, which is a dreaded complication of the mesh surgery. And if that occurs, slowly again, mesh surgery also is going to vanish. So please understand this concept of placing the mesh very, very clearly. The mesh should not be allowed, there should not be any fibrosis. And this mesh has to be clearly kept in that space of heel, or the holy space of heel, where there is less nerves, less vessels, and less fibrosis which are occurring. Now, one of the things which we saw when we started doing this procedure is that when we go down up to the levitrine, we started getting a lot of patients with constipation. So we started understanding, we thought initially the mesh may be pressing on the rectum. So we did sigmoidoscopies. We saw nothing is pressing on the rectum. Ultimately, we understood those days we were dissecting in the wrong plane, which we thought is the right plane. it's not very easy to get into this exact plane. I'll show you the videos, this exact plane, to get into the exact plane. So if you go into the wrong plane, you will start destroying the nerves around the rectum, and this can cause constipation, which can even last up to more than 6 months or 1 year. So understanding this thing is very, very important, and placing the mesh in the correct plane and the right type of mesh in the correct plane is extremely important for the treatment or the long-term prognosis. Basically, the long-term prognosis of these patients with pelvic floor defect. Now, let us look into the other picture you can see here. This is actually a male picture, but it's fine. You can understand that. Suppose here, this is the vagina here. This is actually the penile area, but suppose this is the vagina here. You should understand that the first basic support of the uterus is the levatrine. The uterus or the vagina has to be kept horizontal over the levatrine. If you see the levatrine, let me see if I have a picture of that. Yeah, see, if you see here, the uterus, the vagina, you can see is lying horizontally. It's not really vertical. It is lying more horizontal than this picture actually. And it holds on top of the levatrine. It just rests on top of the levatrine. Now, due to multiple births, think of the levatrine as a median raphe, levatrine as midline raphe. Due to multiple birth traumas, this midline raphe gets torn. Once the midline raphe gets torn, the first support of the vagina is gone, and the next support gets supported completely on the collagen. Now, if the collagen is weak in such patients, then it starts descending down. Then the whole thing collapses down. So basically, what I'm telling is, in all these patients, the vagina has to be kept horizontal and not really vertical. Do not think of the vagina as a vertical structure. When you repair it also, think of vagina as a horizontal structure and directed posteriorly. Posteriorly, where it is always directed, you will find that it is always directed to the sacral promontory or just below the sacral promontory. Now, if you make the vagina anteriorly directed, the entire support which the levatrine gives to the vagina, you know, the vagina is sitting on the levatrine, just lying on the levatrine. So the entire support given by the levatrine is negated when the vagina is placed anteriorly, or because anteriorly there is not much of levatrine. If the vagina is placed anteriorly or if it is placed vertically, then you don't have the actual support of the levatrine. Now, just one word on the so-called Kegel's exercise. Now, Kegel's exercise, we all used to promote Kegel's exercise a lot. But understand, if the levatrine contracts when the central fascia is defective, you will find actually the central fascia becomes more and more wider. So that is why today we do not recommend Kegel's exercise in patients who already have some amount of prolapse. So those patients who already have this prolapse, if you are doing this Kegel's exercise, I feel that it can actually increase the amount of prolapse in such cases where the muscles will get tightened, the muscle will get more larger muscles, and it will slowly tear the already toned or widen the already toned central fascia in between the levatrine. So this is also very important, and Kegel's exercise is a good exercise in patients where the central fascia is not actually toned. Say those who are nulliparous, and you find features of prolapse, or to prevent the prolapse in every patient. any Indian patient who is prone to prolapse, or I would say every Indian patient is prone to prolapse or stress incontinence. So in every patient who is young, Kegels exercise would be a good exercise to strengthen the pelvic floor, but in patients where the central fascia is intact. This is very, very important. Now, so that is the reason why we have always gone for posterior fixation. As I told you, the vagina is directed posteriorly, and any anterior fixation you do has its own problems. And I personally feel the so-called pectopexy, which is actually, I'll get back to that, which is actually an anterior fixation, will have much reduced results. And this is only done for the surgeon's comfort, because the surgeon is not ready to dissect that planes posteriorly properly, or the surgeon is not that experienced. And always I have felt all my life, any surgery has to be designed for the patient and not really for the surgeon. If the surgeon is not experienced in dissecting the posterior plane, he should make himself experienced, because you can see 10 years back, we didn't have much young surgeons coming into this field. Today, you can see everybody doing laparoscopic, even radical hysterectomies. So it can be trained. You can train people in such procedures, and that would be the ideal thing to follow. Now, these are the pelvic nerves, as I said. So when you go in this holy space of healed, what happens is, see, you will see, I'll show you the videos. You will see these nerves which are there on the sacral promontory. These nerves, there is a fascia on top of the sacral promontory. And that fascia, you will find that fascia will not be disturbed, and the nerves will go below that fascia, and we will dissect exactly on top of the fascia and between the fascia covering the rectum. So you will find a good plane of dissection in such cases. Now, another thing which I wanted to tell you before we go on to this Rahman's method of fixing the uterus upwards is that, see, when you talk about a nulliparous prolapse, there are two factors to nulliparous prolapse. One is the uterus is prolapsing. So in the way which uterus prolapses, it also happens due to obvious reason that the cervix gets elongated. So there are two types of elongation of the cervix. One is basically the elongation of the cervix in the supravaginal compartment. The second one is the elongation of the cervix in the intravaginal compartment. Now, whether it be supravaginal compartment or infravaginal compartment, in such cases, it will be always better to amputate the cervix. And when we amputate the cervix, you can shift the fornix upwards. Even if it is supravaginal elongation, you can actually shift the fornix upwards, because you will find the uterine artery always at the level of the isthmus. Internal os. Uterine artery at the level of internal os always. And the cervix elongates below the uterine artery. So you can actually amputate the cervix. You can detach the uterosacral Meckenroth's ligaments from there, and you can actually amputate that much of cervix, bring the uterosacral Meckenroth's anteriorly and tie it. This will give a much better results for the uterine prolapse, even if you are fixing laparoscopically. So this is that's why I said Fothergill is the only vaginal surgery we usually prefer. All the other things are done laparoscopically. Another thing which I wanted to explain is that you will see many workshops also, you will see many workers doing the point fixation of the uterus. They will fix a muslin tape or a mesh just on the cervix and then sling the uterus upwards and say that, okay, uterus has gone up, now everything is fine. But when you deal with this nulliparous prolapse, or any prolapse for that matter, you should understand that this is a complete field defect of defective collagen. And unless and until you correct the complete rectocele, as well as cystocele, plus pulling up of the uterus, it doesn't really work. So if you just sling the uterus from the cervix and fix it onto the sacral promontory, like we all used to do that before, it doesn't work really, because these are the patients who will definitely later on come with rectocele and cystocele, because you have not corrected the rectocele and cystocele. Just by pulling the uterus upwards, you have pulled the vaginal mucosa upwards. So you feel that you have corrected the rectocele. It doesn't work like that. Later on, it will definitely relax. So your dissection has to go right up to the levatrinae. Up to the levatrinae means the complete length of the vagina up to the perineal body is covered. And the mesh will come between that full length of vagina and the rectum. And that is how the rectocele is completely prevented. If it is a cystocele, you should understand whether it is a paravaginal cystocele or a central cystocele, and the correction goes accordingly. In a paravaginal cystocele, you should enter into the space of Ritzius and then correct the paravaginal repair, rather than correcting a central correction in all types of cystocele. You know, previously we used to do a central correction in all types of cystocele, and this defect can be actually got through MRI. A good MRI can actually understand clearly whether it's a paravaginal or a central cystocele, rather than going in for clinical examination. Or I understand, of course, clinical examination to some extent, you will understand whether it's a central or paravaginal defect, but not really fully to warrant a correction. Or else another thing which you have to do is you have to dissect that space of Ritzius. When you dissect the space of Ritzius, you will understand the lateral defect of the arcus tendineus, and you can repair it. And if there is no defect, you can leave it at that point and come back. Now, in this Rahman's method, what we do is basically see, you can see that is the sacral promontory. Now you can watch carefully, you can see the different planes of the different planes here. The first plane which I am cutting, this is the plane of the sacrum. We are not going into the sacral plane. I can go here also, this will also look avascular, but you can see I'm cutting one more plane and I'm going deeper down. Can you see this plane? In this plane, you will find that there is another fascia. There is a separate fascia which will move on the sacral promontory. See, this is the sacral promontory. You can see this is the sacral promontory, right? See the sacral promontory? You can see all the vessels and nerves. Your concentration should be here and not down. You can see all the vessels and nerves going inside that fascia down. And we are dissecting into completely avascular plane. And you can see one more thing also. Just look at this one. You can see one more thing also here. The fascia on the rectum. Look at the fascia on the rectum. See, here you have a fascia on the sacral promontory. You can see all the vessels and nerves going on the sacral promontory completely undisturbed and not exposing the bone as such. You can see the fascia, you can see the vessels, you can see the nerves completely undisturbed going below the fascia where I am operating. Here also above you can see there is a fascia on the rectum. The rectum is never exposed. You should not see the muscularis of the rectum at all. The moment you start seeing the muscularis of the rectum, understand your dissection is not good. The dissection has to go exactly in this space of field. And you can see there are multiple ligamentous points. Can you see this white one? These are multiple small ligaments which hold the rectum or the vagina upwards. You will find n number of these kind of ligaments which will hold these things upwards. It's not just the uterosacral mechandroids and round ligament or the pubovesicocervical ligament. There are n number of ligaments which will hold the entire tissue upwards. So you have to dissect in this plane, exactly in this plane, then only you can actually succeed in getting into this thing. So you can see the plane very clearly, and going down, you can see here also. Can you see that sacral promontory? So going down, you will reach up to the piriformis is the first muscle you will see in the pelvic floor. Now, when you dissect here, you have to be away from the ureter. I have seen in workshops some of the faculty, they dissect the ureter in these cases. They say that they want to safeguard the ureter. Never do that mistake of dissecting the ureter when you are keeping a retroperitoneal mesh. Because if the mesh stands on the ureter, when the mesh is there, you have dissected that ureter, means there is all chance of the mesh going on the ureter. And if the mesh touches the ureter, you are bound to get again fibrosis on the ureter. And that is the reason why we never dissect the ureter when we get into these planes. Here also you can see there is a stretch which is maintained. Again, you can see the nice plane coming there. This is where you go between the two layers of denuvulus fascia. Can you see that? You can see the fascia on top of the rectum. You can see the rectum below. You can see the vagina anteriorly. So you have to go between the two layers of denuvulus fascia, dissect down up to the pelvic floor. That is a levatrine. You can see the levatrine on the right side here. You can see the levatrine, and you can dissect the levatrine on the left side. Then what you keep is a mesh. See, this mesh ideally, this is a titanomized mesh. This is not the usual Prolene mesh. Ideally, you have to keep a titanomized mesh, and you are fixing with an absorbable tack onto the levatrine. This is just to keep the mesh there. Now, nobody is going to hang on it. You can see the mesh very well placed between the rectum and the vagina, right? Now what we do is we take it up. You can see the mesh is kept very loose. Can you see that? I'm not pulling the mesh upwards at all. The mesh is kept quite loose, and onto the sacral promontory, you are fixing it with non-absorbable tacks. I do not want to suture on the sacral promontory, basically because when you suture on the sacral promontory, you will take a large chunk of nerves and vessels and tie it. That is, when you put the stacker, only one point you are going inside. So the chances of having a nerve damage is much lesser when you put the stacker than suturing. This is very, very important point. And when you put the tacker, you should be seeing that there is no common iliac vein. Common iliac vein is very important. So one thing is the mesh is kept very loose, and then you are fixing the cervix onto the mesh. Now, previously we used to fix the posterior cervix onto this mesh, and every time when there is a recurrence, what happens is it gets detached from the posterior cervix. The mesh is still there. The detachment occurs from the posterior cervix, and then it gives off. Now here, I am taking a muslin tape. You can see a muslin tape is taken right across the cervix, around the cervix, and I am fixing it upwards. See, this is the point where you tighten it. The mesh will be tight only this much distance. Lower to this, the mesh will not be tight. So here you are just tightening that mesh here. As you can see here, you are bringing the muslin tape upwards, and you take a bite on the anterior also, and then you are fixing the muslin tape nicely. Nicely you can fix the muslin tape, and you will find that this uterus no way can come down again. Very, very important, because so far in this Rahman's method, we have almost zero recurrence of uterine prolapse following this fixation. Because how can the uterus come out? Because the mesh cannot cut through the cervix, amputate the cervix and come. Neither this mesh which is fixed onto the sacral promontory with 2 or 3 tackers cannot. This you can see here. You can see very important thing. This cannot come out by the tackers coming out of the sacral promontory. It should be very, very rare. When you look at the vagina in these cases, you should find that the normal rugosity of the vagina is well preserved. This is very, very important, because overcorrection of the vaginal prolapse, overcorrection of this prolapse, reducing the rugosity of vagina will actually create more issues like stress incontinence, especially the anterior overcorrection. So here you can see that the normal rugosity is more or less preserved in these cases. So then after putting all these things, you can just peritonize the mesh completely, and that is all which has to be done. Not a close to the full. Oh. Now, see, when it not only the uterus, when it comes to the vault fixation also, it's very important to understand how we fix the vault in these cases. See, here you can see the mesh which is kept, as I said, and you can see an amputated cervix. Many cases of prolapse, if the patient is actually affording to do all these things, we never repair the prolapse vaginally. So only in those patients who are very poor, we do a vaginal repair. So if the patient can afford all this tacker and all those things, always laparoscopically. And you can see if it is an amputated cervix, the chances of mesh erosion is much lesser. We usually do not use this. This is ethibond. Nowadays, we don't use ethibond sutures. We usually use the ethilon. Now here you can see how the vault, when it is cervix is removed, is fixed. What you can do is there are two methods. One is this one, where you are fixing the posterior vaginal vault upwards like this. As you can see here, the posterior is alone fixed upwards. And once you fix the posterior, then you fix the anterior little below. See, this is the posterior fixed with 3 sutures. And then the anterior sutured little below the posterior vaginal wall, so that the chances of mesh erosion will be much lesser. Number one, the chances of stress incontinence will be a little less because anterior is not that much pulled as the posterior. So you are maintaining a little cystocele in those cases. So as you can see here, we are fixing the anterior down here. And then with continuous sutures here. You can see that, and that is the anterior vaginal wall. So that anterior vaginal wall, you can take the full thickness of the anterior vaginal wall. And the second bite is taken little below the fixation of the posterior vaginal wall. Can you see that? So it's taken little below the fixation of the posterior vaginal wall. It's not that the 2 raw ends are sutured together. So it's like overlapping that thing. So the anterior goes little below, and this will help preventing some amount of mesh erosion in many cases. So as you can see here, and even in cases of a vault prolapse, you do the same method. Vault prolapse, you're not opening the vault at all. So this is how you can fix it. Can you see that? And if there is a central cystocele, that is another thing. If there is a central cystocele, you have to dissect the bladder completely down. You have to dissect the bladder completely up to the urethra, and laterally also below the ureter, you have to go up to the arcus tendineus laterally. Unless you dissect it like that and keep a mesh there, the cystocele will keep recurring. Only in a lateral cystocele, you need to go and do a paravaginal repair in such cases. So here you can see it's a central cystocele, and you are keeping a mesh here. A mesh is kept anteriorly also. This mesh, we keep a macroporous mesh, as you can see here. That is a bladder, and then you can repair it completely. That is what we have already shown. Now, see, many of us have problems with this mesh, and even there are some patients who have certain allergy with mesh. And in those cases, what we are just trying nowadays is that you can take the rectus sheet. See, as you can see here, we used to take the fascia lata before. Fascia lata was taken from the thigh. So now it's very difficult to take fascia lata. So the rectus sheet, see, in the abdominal wall above the umbilicus has two rectus sheet. One is anterior and the other one is a posterior. The abdominal wall below the umbilicus has only the anterior rectus sheet. So here you can see the ribs, you can see. Now take the rectus sheet down. As you can see, you can cut it and take a good length, good width of the rectus sheet, as you can see here. That is the posterior rectus sheet of the posterior rectus sheet above the umbilicus can be taken. Initially, you can see we have taken the falciparum ligament. And as you can see here, we are taking a good width of this rectus sheet. And this rectus sheet actually can be used as the fascia. You'll get a very good length of the rectus sheet, as you can see here. See that? This one can be used as the fascia. This is actually the rectus sheet with the peritoneum on top of it. You should understand which plane you have to go to harvest this rectus sheet. That is again very important. So as you can see here, we'll cut it and take it. So that is how you can take the rectus sheet, and that is how you can fix the rectus sheet onto it. Now, combined paravaginal and anterior fixation is one of the most dreaded thing, because the problem of this combined anterior and paravaginal repair is that you have to dissect the posterior part of the bladder and you have to dissect the anterior part of the bladder when you go into the paravaginal repair. So this is where I am also a bit confused when you have a combined paravaginal and the central defect combined together, where to dissect, because if you dissect anterior and posterior, there is all chance that you will destroy a little more of the nerve supply to the bladder, and bladder atony is always possible. So you need to be very, very careful. It should be a completely nerve sparing type of procedure when you do that. Now, this is where you find the this is how the pectopexy is done. Even though the people who promote pectopexy, even though they say that this is fixed laterally, it's not fixed laterally. You can see that it's fixed anteriorly. It's fixed anteriorly onto the pubic bone and the lateral part of the pubic bone, the pectineal ligament. Just like the old birch which we do, we fix the, with the mesh, we fix it onto the pectineal, we used to fix it onto the pectineal ligament. So anterior fixation, as I always said, which is completely inferior to the posterior fixation, basically because the vagina gets directed anteriorly. More than that, you should understand that this point which you see here, this point which you see here, if you see, it is just 3 centimeters away from the introitus down, because that is the thickness of this pubic bone. The pubic bone is just 2 to 3 centimeters thick. So you are just fixing the vagina and the uterus 3 centimeters above the introitus. That is anterior thickness. But if you see, look at the fixing of the posterior fixation, you are fixing it almost very close to the sacral promontory, which is the obstetric diameter. That's obstetric diameter, which is the obstetric diameter. Sorry, I forgot this obstetric. That's why I asked her whether it's obstetric diameter. So that's the obstetric diameter, which is almost 12 centimeters, or it has to be, it can be even 13, 14 centimeters ahead. So that is the actual length of the vagina. So the complete length of the vagina is on the direction also. It has to be directed posteriorly for good sexual contact. It's not anteriorly, which has to be directed for good sexual contact. So the length of the vagina is completely preserved in a posterior fixation. The only problem in posterior fixation is the surgeon has to be good. And pectoplexy, another problem which I have is the point fixation. You're just fixing the uterus and pulling it up. You're not going down on the bladder and putting it right up to the arcus tendineus in these cases, which is actually very, very important also. Now, it is also important to prevent the prolapse in many cases of hysterectomy. Again, see, this is how you can do a Moskowitz. You can see the uterosacral. Either you can do a Moskowitz, or we used to do a lot of high McCall scaldiplasty. It's almost the same. So you can fix the uterosacral here like that. Then take the vaginal wall. And then you are going to the other uterosacral also. And you can see that this has gone through the other uterosacral here. Can you see that uterosacral? Then fix it on the in the center. And after fixing both the uterosacral and closing the vaginal wall, like this, then what you can do is you can do the Moskowitz operation, where you will close the deep pouch Douglas. See that? So you are taking this one, the lateral part peritoneum. You are taking the rectum, anterior wall of rectum. It's not really uterosacral plication. It's basically Moskowitz. So you're taking that peritoneum, then you are taking on to the uterosacral ligament. Of course, the uterosacral ligament comes a little closer. More than that, you're putting a purse string in the pouch Douglas, reducing the depth of pouch Douglas, which will prevent a lot of enterocele basically. So this will not prevent cystocele and rectocele. This surgery done with the hysterectomy will only prevent apical prolapse. Apical prolapse and enterocele can be prevented, but whatever cystocele and rectocele is much below, that will still occur even if you do this prolapse surgery to prevent the apical prolapse. So that is also again very, very important. So let me see if I can show you this video.
The cable was pulled out by the staff.
Okay.
So we are restarting the system.
Yeah.
No, till then can we continue
We
with
can continue with Dr.
Can you see the video now?
Sir, we were already with.
Are you there still with me?
Yes, sir. We can see, sir.
You can see this video that trocar going inside?
Regarding
Yes,
the
sir.
fascia,
Yes,
sometimes
No, I'm just wanted to, this is an unedited video which you can see.
And
I just wanted to show you the anterior repair.
my grasper.
this is
Because I don't want the mesh to be exposed to the cut part.
yes, sir.
Again, you need to stick on to the correct facial plane.
So this is,
As you can see here,
So the
That is-
starting point for this dissection
you
is
can see the plane, see the correct facial plane you can see. You see, you will not
sorry,
see
I
the
didn't get
bone naked when I
what is
go
the
there.
starting point for this dissection.
starting point. You have to see the bladder ends. You have to see that fat area and see the fascia, and then you can decide where the bladder ends. From there you can start. Now this plane again is has to be a good plane, very important. And again, one thing you should understand is here you should not have the pubic bone fully naked.
The fascia has to be there.
See that?
Yes.
Here, this is the pubic bone. Can you see that?
Yes, yes.
But you can see the fascia on top of the pubic
So
bone.
that is what
Yes,
we are
we can
telling.
see
See?
that.
See, the pubic
This
bone should
pubic
not be
bone,
fully
I can
naked.
take the fascia
You
here
should
and
see the fascia. That's see that?
Yes, sir.
You should see
this
the
is how
fascia
many
on top
people
of the
do
pubic bone.
in
See,
this
this is very
plane.
important.
Wrong.
Most of the
Can
people
you see
go
that?
in this
Okay,
fascia,
yes, yes.
That's
and that is
facial.
a
See,
wrong
wherever
plane.
you dissect, no, it has to be
Not where you have to
natural.
put on
God has
fascia or
actually
dissect.
created natural
So
planes
there is
of
a natural
dissection.
plane here.
Very important. See
This
that?
is very,
How
very
it goes?
important. So all this
The vessels
fascia,
and the nerves
where
are
I'm
not
dissecting
there in this
beyond
plane.
also there
See?
is a fascia.
Yes, sir.
On
Can
the
you see the
psoas
pubic
muscle
bone?
also you will see
You
a
can see the
fascia.
fascia on top of it.
Yes, yes.
So on the
So
bladder
this is
also you
very,
will see
very
another
important for
fascia.
any
And I
dissection.
am dissecting between
I know I
those
have
two
learnt
fascia.
it over a large number
So
of
this is
cases,
very,
but I
very
can
important. You can
give
see
it to
I
my
have now
students, this dissection. See?
the operator
Can
muscle
you
is
see
there.
none of the
You can
vessels are
see that
getting
there is a
damaged? See
fascia
that?
on top of the
Yeah.
The
operator muscle
arcus
also.
tendinous. See? This
Yes.
is the arcus tendinous or the
Perfect.
white
Very,
line.
very, very
Can you
nice.
see the arcus tendinous?
Yeah.
And you can see that the arcus
So
tendinous
you
is
can see the
detached.
arcus
See?
tendinous here.
I have gone below the arcus tendinous. Can you see that?
Yes, sir. Yes, sir.
Below the arcus tendinous, which shows the paravaginal defect. Can you see that?
Yes, sir.
Normally, I will not be able to go below the arcus tendinous. See?
We have got lost picture from Dr. Deepak's OT. Can we connect it?
So that is where we went below the arcus tendinous. You can see the arcus tendinous here,
The picture is lost.
and you can see it is detached below. And I'm gone below the arcus tendinous,
Hello.
and I'm going
Hello.
into the
Yeah.
where the
Sujal,
pudendal nerve goes in the
actually,
ischial fossa. You
one
can see the ischial
cord
fossa
cable was
here.
pulled out by the staff.
Okay.
So
the
we
vision
are
is
restarting the
temporarily
system.
Yeah.
No,
We did not dissect the
Can you
bladder.
see that?
Yeah.
I'm not dissecting the bladder. See, this is the
Yes, yes.
natural
Now you
thing.
can see
Yes.
the
Bladder is only
vagina
up to
on
here.
the left side.
So
Okay.
you attach that
Now
fascia.
here also you see this is the bladder. See, this is the, can you see the bladder? This is the bladder. Should understand the tissues. You have to be friendly with the
The vagina.
Understand the tissue texture.
This is the vagina.
Another one here is
No
the
confusion.
bladder.
This is the bladder. See, you should understand the tissues.
Understood
Of course, it has to be done by a large
Vagina very
number of
clearly.
cases.
You can see the
Okay.
arcus tendinous
See,
clearly.
this is where you do the birth
bladder
also.
also
no?
here very clearly. So this
Okay.
tissues.
Now I will start the paravaginal repair. So here you can see the arcus tendinous. See that?
Yes, sir.
Okay.
That is arcus
You can see
tendinous.
the defect gone down. So I have to suture this one to the arcus tendinous. This structure. This is what structure?
Obliterated.
Obliterator umbilical.
That's
Median umbilical ligament,
Then you have the operator
Okay.
nerve here.
which goes just lateral to
anatomy
the
there.
inferior epigastric. Inferior epigastric is a branch.
That.
has scrubbed out.
Yes, sir.
So
And
So now we are starting to suture it.
Shri, still the pressure is low.
And this is the workshop which is unedited. So this is how we suture the paravaginal.
and now I'm going to
You can
merge.
see now you can
This
see that the arcus tendinous is no more visible.
nerves to this
You
side. Can you
sutured
see
the
that?
paravaginal
Operator nerve is
defect
cleared.
almost completely here. Then I'll go to the
And
opposite
this is
side also.
observation.
That is the vagina. You can see the arcus.
Dr. Deepak,
Okay.
you're on.
So that is where we suture the vagina onto the arcus tendinous, as you can see here.
Little bit. You can work like a millimeter by millimeter.
Yeah. We are really using a tip.
See that?
Keep
That
and
is arcus tendinous. So
and
that
that
is
will
the
work, if you work
paraurethral area
millimeter,
which
it
is
will work
sutured
for
onto
10
the arcus
millimeter.
tendinous. We use a wheel of sutures here,
See like that.
which would be
Okay.
the most ideal thing to use.
It will stop cutting.
Yeah.
So, sir, safety point of view,
Can you see this node?
See that?
Yes.
You can see that the paravaginal defect is
take
getting
it.
closed.
Yeah.
And when we pull it completely,
કઈ ના કરીશ. હવે પકડ.
so you should understand where the bladder is and where the vagina is.
પકડ તો આખું પકડ. હા.
Yes.
નીચે નાખી દે.
Now when I
drop
pull
that
it,
knot toward the obturator fossa, so it will be at the. So I would advise.
you can see both sides now. We have sutured it nicely on the paravaginal side. You can see this side also.
Deepak will just come back to
See
you.
here also.
Dr. Hafiz has just finished the facial repair.
Yeah, we are shifting the audio to Dr. Hafiz.
Sure, sir. Sure.
Yeah, Dr. Hafiz.
Hafiz,
Here-
sir, we can
here-
beautifully see the.
You can
defect
see
close.
the repair here.
Yes, sir.
The defect is closed. We don't go up to beyond this area because that goes posteriorly.
That is the
actually.
pararectal.
You can
Beyond
see
this
here
area goes
almost
to the
3
pararectal.
centimeters. This is the, you can see the pubic, you can see the bulb of Foley's. So up to here the urethra comes.
Yes, sir.
So this is the paraurethral here and the bladder vesicle. We have repaired it completely
most of the
and you can see that.
cases here.
We prefer to keep some amount of
So thank you so much for your patient listening. I hope you enjoyed this concept and the right method, which we feel personally has to be done. So thank you so much for all your time and thank you for the invitation.
Yeah, you can take over. Yes, Vidya.
Sir, thank you so much. Thanks for the brilliant presentation of pelvic floor defects and also telling us, in fact, you have proved that pectopexy you should not do anymore. You should do the posterior repair. I think you have completely proved and showed how the levator ani has to be lifted. And recently, Nikita was in my place to do e-endoscopy, and she also did it so beautifully. Lifted the complete levator ani, and then the mesh was fixed. Now, I have one doubt, sir. What is the incidence of constipation or mesh erosion in this procedure?
See, the incidence of constipation, initially when we used to do this procedure, the incidence of constipation was a little more higher. Because those are the times which we were also not understanding this concept of the correct plane, that is the holy space of healed. So we were not understanding, and we were also be going little into the other space and destroying the nerves which are supplying the rectum. We may not damage the muscularis, but we will be going in a different facial plane below the, just above the muscularis. And that will damage the nerves which will actually produce constipation. The constipation is not due to the mesh or mesh holding on or compressing the rectum, not at all. The constipation in these cases is always due to nerve damage. So if you can stick on to this correct plane, that's why we are telling the correct plane is very important. If you stick on to the correct plane and put it, ultrasound, when you do the ultrasound post-operatively, you can actually see that the vagina moves on the mesh. Or you can see that the rectum will move on the mesh. This is very, very important. The mesh is not getting fixed on to any of these structures. The mesh is staying in between the two structures, avoiding a rectocele. So this is very, very important, and that's how we can prevent constipation. Now, the rate of constipation in our cases may be around 5 to 10%. That's it.
Okay. Incidence of mesh erosion, because we are, should we use a mesh or not? Even surgeons, like they have stopped using intraperitoneal mesh, because today I was doing a hysterectomy and it was an intraperitoneal mesh which was inserted, the Covidian mesh 4 years back, and the bowel was completely stuck to the anterior abdominal wall. So here, what is the incidence? You're using the regular Prolene mesh. So what is the incidence of mesh erosion, sir?
Now see, number one, do not use the regular Prolene mesh.
Okay.
Use a titaniumized or a composite mesh which will not get adherent. That is the most important. If the mesh doesn't get adherent to the rectum, then the chances of rectal erosion is very less. Number two is that if you are in the right plane, again, the rectum will not get adherent to the mesh. The chances of erosion is much less. Luckily, in my cases, till now, we have not had a single erosion. It's like every week we may be doing 1 or 2 or 3 cases of prolapse every week. So till now we have not had a single erosion, but luckily, but now I am very clear that I will not further have an erosion of mesh, because now we get into the correct plane. Previously and all, we were not getting into the right plane as I'm showing now. We were also going into the wrong plane. We didn't understand the concept of this right plane. Those days could have actually had mesh erosion, or maybe those cases where we did surgery, that those days may come back to us with mesh erosion. Maybe after 10 years or 15 years, they may come back. But now we are pretty sure that these cases, if you're putting the mesh in the right plane, you're putting a titanized mesh, the chances of mesh erosion will be almost zero. It's very important to propagate this concept, because what is otherwise going to happen is people put the mesh in the wrong plane, people put the wrong mesh also, and they will get mesh erosion, and ultimately some of these organizations or the court will come and say mesh will have a lot of erosion into the bladder, bowel, rectum, stop mesh completely. This is not the answer. Okay, if I can have another thing to put instead of mesh, then I understand mesh can be stopped. But doing it in the wrong way and then putting all the blame onto the mesh will not be right.
So your take-home message is use Prolene mesh. That is your, advice to us. So anteriorly, have you ever tried a mesh in a cystocele repair? Because there was one time when this Pro-G, Apo-G, everything came, and all of us, they all promoted, especially Ethicon, they promoted the vaginal mesh, and then that was a failure. So if there is a cystocele, you beautifully showed us how to go into the space of Ritzius and correction of the cystocele. Does that space have any role of mesh?
The paravaginal cystocele repair does not have much role for mesh. Only when you are combining it with a Birch-Colpo suspension, where I use mesh for Birch-Colpo suspension. Maybe I will be the only person using mesh for Birch-Colpo suspension. All the others are tying the paravaginal area to the Cooper's ligament. But I put a mesh on to the paraurethral area, pull it on to the pectineal ligament. It looks something like pectopexy. But from the paraurethral area, not from the uterus, paraurethral area on to the pectineal ligament, actually it used to work very well for me, even though recurrence rate was little more higher than the TVT tape. And then do a paravaginal repair. So when you do in the paravaginal repair, we don't use mesh, because that is only a detachment of the vagina. That is not only collagen defects, basically a detachment of the vagina from the arcus tendinous. So there you attach the vagina again back to the arcus tendinous, it will be fine. But when it is a central cystocele, it will be better to keep the mesh. There you have to be very careful, because the space between the rectum and vagina is much more clear than the space between the bladder and the vagina. The space between the bladder and vagina, you have all chances of going into wrong place in this wrong plane in this space, because it's not that open or that loose. So that is where you have to get into the correct plane. And not only that, you have to dissect right up to the urethra. And laterally also you have to dissect, otherwise you will again get a lateral cystocele. Laterally also you put the mesh right up to the arcus tendinous, otherwise you will get a lateral wall defect and the vagina will come out laterally.
Anybody else would like to have a comment?
Yeah. Thanks for completely enlightening on those aspects, sir, because there are so many gray zones. Do we have to do? Do we don't do? And there's always a question mark. But I
hope I have not confused you more.
No.
Anybody else has got any comments, please?
Because this is a completely new concept which I am trying to bring in. So it should not be that you get more confused. And all these other POP-Q and all those things, practically, I don't use at all. In my practical experience, I don't know how much effective using this POP-Q classification and all those things is that effective.
Post-graduation exams, sir. After that, I don't think it is necessary.
What is not needed practically should not be there for exams.
If anybody else has got any questions, please ask them.
There is Madhu. Anybody who wants to ask? Bharti, I can see
you. You have to be a bit careful when you don't have the videos. In webinars, no, they must have some people go for cooking Some people go for surgeries and come back.
Yeah.
Sir, excuse me, sir. In the first video that you showed,
Yes, Madhu.
Go ahead.
Yeah,
sir,
please.
in the first video that you showed, did you fix the with the tacker to the lever trani muscle, sir? That you didn't show.
It's not tacker, that is absorb tack. See, that
Absorbable
is an absorbable clip. Later on, it gets absorbed.
So you fixed the caudal end, the lower end to the
Fixing it
lever
like
trani.
that to pull it. No pull occurs on the lever trani actually. The entire pull will occur from the sacral promontory. So the uterus is going downwards. No? So the pull will be from the sacral promontory. This is just to fix the mesh there.
And also to that mesh to the Marcelline tape to the cervix.
Yes, around the cervix. Only problem with this is that the patient becomes pregnant, she will have to go for a C-section because this will be like a cervical encephalopathy.
Laparoscopic cervix.
Shall we wind up, Vidya?
Yes, sir.
Anybody else?
Yeah.
I think it is almost, sir, has taken 1 hour.
Oh, I'm sorry for that.
Sir, thank you very much for elaborative and explaining all the new concepts and showing all the basics also. I think one very good remark you did in the opening statement is that all these defects will occur in a woman who has got really congenital defects of collagen tissue. I think that statement is the statement which can make us everybody to understand that there is a need to use the tissues which are not from her body, from outside. I think that is how the concept of mesh came into picture. I think extensively we have used mesh and you have given all the data, what are the side effects and all that. And your videos were so self-explanatory. Anatomy of the pelvic floor was so easily understandable for everybody. And your Rahman's method in treatment was also really. I was thinking when we were postgraduate students, this supravaginal elongation and infravaginal elongation. Today also you have highlighted in that. I think that is the basic understanding one should understand whenever there is a defect and the prolapse. And the level of the uterine artery also you have really again made mark that you must know where exactly the uterine artery is there. Walt fixation procedure also you have given very nice. Sir, I was very fond of this Muscovite procedure. In every hysterectomy I used to do, and I used to feel that I am reducing the pouch of Douglas depth. That may be the reason that the Walt incidence, prolapse incidence was very
reduced.
Yes, sir. And fixing to all these tissues, though we say that ligament is not so important, muscle is not so important, fascia is not so important. I think bringing all them in the center and strengthening them will give a good result. That is my personal feeling, sir. Otherwise, the talk was excellent. I would have felt much more teaching faculty should have taken this opportunity. Sir, we have got 62 medical colleges in Karnataka. And we have got 10 to 15 faculty who are the teachers. And you can imagine there are 700 to 800 teachers. I think all teachers should understand this. If they don't understand this concept, they cannot be a good teachers at all. That is what is my feeling.
Sir, we are coming up with, I'm not sure how many delegates you have now.
Yeah,
but,
yeah. No, I am not very happy with the number of delegates.
Yeah.
And we have taken your time and we have taken
But
so
we are
much.
coming up with a new program to propagate the concept of laparoscopy correctly among the youngsters.
Yes, sir. Yes, sir.
This program is we are taking basic training for laparoscopy, completely free of cost, for 2 days. So these youngsters can, each batch will have around 30 people. So we will tell them what is laparoscopy and all those things, and we will allow them to enter our OTs. They will see what is happening in laparoscopy. These are for young people.
Yes, sir.
Now, out of those people who have undergone this basic training for 1 year, we are giving them a scholarship. One person will get a scholarship every year.
Very good, sir.
One person will get a scholarship every year of 16 lakhs. But I'm not giving the 16 lakhs. We are taking that person for our advanced training. For 6 months or 1 year, that person will be with us. He will get completely trained in laparoscopy because this 6 months training, which we are charging 16 lakhs right now, is going on, and it's a completely booked training. So this person will get an opportunity to get this free training for 6 months, and we'll ensure that that person will become a very good laparoscopic surgeon.
Yes, thank you for giving all this information. Now, as a teacher in the medical college for last 3 decades, my feeling is we have teachers. We have aptitude of the teachers to teach them. Now, what I am finding is learners are becoming lesser and lesser. That's why Vidya, every time I tell them, we can take the horse to the water.
Yes, sir.
It is left for the horse to drink or not to drink. We have brought the best of the teacher, Dr. Hafiz Rahman, at their doorstep, at their house, and they can sit in their house and enjoy. I think they have enjoyed today. Thank you very much for taking your off time. I know you are such a busy person. You have given so much respect to our request. KCOG will remember your talk for a very long time. We want you to have at some time, some other time on this forum, sir. Thank you very much on behalf of all KCOG office bearers and KCOG office bearers, sir. Thank you. Thank you very much, sir.
So we look forward for another workshop in KCOG conference, sir.
Yes, yes.
And always more than happy to invite you for a workshop because it's a joy watching you operate.
Thank you and namaste, sir.
Thank you so much.
Thank you, sir. Thank you.